Good afternoon. This is Matthew Clay with JBS International. Thank you for joining us for today's webinar, Addressing Workforce Issues of Retention and Recruitment, a learning collaborative. Before we begin, I'd like to review some housekeeping items. Due to the high number of participants on this call, all participant lines will be muted for the duration of this webinar session. If you have any comments or questions, please submit them at any time by using the Q&A feature. To open your Q&A window, please click on the Q&A icon located in the bottom center of your Zoom window. Closed captioning is also available. You can view the captions in your browser by clicking on the AI media link in the chat. If you experience any technical issues during this webinar, please message us using the chat feature, which is located at the bottom center of your screen, or you can email us at samhsa@jbsinternational.com. Please note, this is a recorded event and your participation grants consent to be recorded. The recorded webinar and PowerPoint slides will be made available and sent to participants at a later date. Lastly, I would like to provide a few remarks to lay the groundwork for today's presentation. Today's webinar is the culmination of an intensive multi-session learning collaborative that select states completed. Each session included national subject matter experts who presented key strategies and best practices, breakout group discussions for participant interaction and sharing, and activities predicated on strengthening state workforce. The purpose of today's webinar is to ensure the work, lessons learned, and key findings from the collaborative are shared with the broader audience. Co-leading today's presentation includes several state participants sharing their takeaways via state spotlights. As these spotlights are shared, I challenge you to take note. There will be future learning collaboratives available to states. Because of the limited number of spots, there will be a selection process. States interested in learning more should be on the lookout for further instructions from their GPO, and any questions may also be directed to samhsa@jbsinternational.com. At this time, I will turn it to Jim Sacco, JBS International and Learning Collaborative Facilitator, to get us started. Jim? Before I do that, I'll quickly read the disclaimer on the slide. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. Sorry about that, Jim. The floor is yours.
No worries. Welcome, everybody. Thank you for making time. My job is to kind of get us through a bit of content here at the front end. That's my CV on a slide. Basically, my parents spent a lot of money for college, and I'm a really old guy. That's, if I were to summarize, that's what it looks like. Here's our agenda today. I'm going to try to encapsulate 6 instructional hours from our external consultants into 15 minutes. So I have had a lot of iced tea today, and I'm trying to just give you a broad overview of what we've heard. Again, I won't be reading these slides, and as Matthew said, these slides will be available. So please don't make yourself crazy. I just want to give you some of the highlights of what we heard from our external consultants. Our 2 state spotlights, Brandon Beckman is going to step up and talk about the experience as a learning collaborative participant and what he brought back and learned from his colleagues in Nevada. And my cousin John Valera from the Hawaii State Department of Health was also part of this, and he'll do the same thing, talk about what it meant. Finally, we're lucky enough to have Jessie Boucher from the University of Nebraska Medical Center. And she will be she's been kind enough to sort of look at the landscape of what's new and innovative, and we'll end our day kind of thinking about what future directions for research and programs. So we're delighted. This has been our motto all along, adapted from Project ECHO. We've all had a collaborative learning process. Partners on this, SAMHSA, and our partners at CSAT have been kind enough to offer guidance and support for us. JBS International, the primary contractor on the state TA task, has manage things. And then the 7 states that were part of this were part of the agenda, part of helping create this for us. So we began in week 1 with a discussion about the importance of a diverse workforce. And again, that's not news to anybody. A wonderful presentation from colleague from Texas, Sue Gallego Viejas, talked about the importance. Here's the current state of disparities. Not surprising, I suspect, to many of you, but what exists is a workforce that doesn't in any way approximate the need of the patients that we serve. Another example here, just a snapshot of who's in the behavioral health workforce. And I probably don't need to tell anybody in this call that your patient population looks really different than those numbers. We included a quote, Sue included a quote in her slides, sort of as many people have alluded, that in some ways COVID-19 held up a mirror for us and pointed out flaws in our culture, pointed some of the ways our system is threadbare. And so the Annapolis Coalition is a think tank based in Maryland who sort of offered some guidance on what the workforce ought to look like. Jesse and some colleagues have done work on what happens if providers look like the patients they serve. Not surprisingly, those outcomes are better when the person I'm seeing looks like me. Donald McDonald, who's on the JBS staff, was kind enough to do a fantastic presentation on the role of peers. I think we all acknowledge that peers have to become part of the solution to workforce issues. And so he sort of talked about the patient satisfaction issues. What we know is when you look at issues of peers, the language of recovery and resilience in SAMHSA language inherently speaks to recovery and what recovery will look like. We had resources from the SAMHSA Center of Excellence on using peers that were also part of that. As I said earlier, Donald talked about resilience and the role of peers and what peers do. And part of the discussion, part of our challenge has been, I think, for all of us, sort of looking at how the role, within appropriate parameters, how the role of peers could be enhanced in solving the workplace issues. So some other ideas, including what about creating a leadership structure where supervision of other peers, we sort of thinking about administration, thinking about acting as advocates and pushing on changing policy. All those roles are sort of beyond what's typically expected of peers in the workforce. Week 3, we had a wonderful conversation with Dr. Baloo from the Council on Social Work Education. So while the focus on working with young career professionals was rather focused on social work, she also has managed nurse practitioner, health educators, other academic schools of preparation. So she brought some interesting information. I think what I took away was, obviously the existing problems that we all know about, and some work that they've done at CSWE about how to retain students who are in positions of internship practicum. I thought her talk for me was especially compelling. I mean, she drew a pretty hard line that thinking of student labor as sort of free labor and this sort of exploitive model really isn't a model for solving our problem, really isn't a model for the 21st century. That one of the things she talked about, again, all caps in bold, not all permitted with your current block grant money, but talked about students expecting some incentive to work, and some of that's tangible. Those bottom things kind of think about what kind of workplace you're creating. What she drove home is every student needs practical experience as part of their degree, and we need help in the workforce. The two things that she came back to that were compelling to me was this bottom bullet, payment for placement, the idea that at CSWE and increasingly other academic support agencies that people are looking for compensation, equity in compensation for people who are in placement. I guess the other thing I took away is, again, rather than this sort of short-term exploitive relationship, she talked a lot about internship as a career pathway for students in schools of preparation. One of our colleagues, Mark Atanasi, joined us on week 5 to just sort of go over the basics of human resource. And so one of the things he talked about is just sort of being really mindful about looking at resume, looking at the interview process, working with your HR folks. We've had a lot of conversation within the Learning Collaborative about teaching HR what we need, working in an advocacy way to help human resource people kind of understand ways in which their flexibility, their cooperation can help help solve some of the workforce issues. Mark lined up pretty quickly on an in-person interview process where that's possible. I think more and more we're increasingly moving away from Zoom hiring, and he raised some concerns. The other thing, again, back to sort of the basics of HR, kind of how to be a good manager, what people are looking for in terms of supervision and support management. And then really, again, we kept coming back in the collaborative to the role of creating a workplace that people want to be in, the tangible things that employees need, like health insurance, and also the relational things like these traits of successful supervisors. And just, again, that reminder to us about what happens in the workforce when you're attending to all of people's needs, not just pay and health insurance. And we ended the collaborative with a discussion, an expanded discussion about resilience and retention. The idea here is in focusing on solving the workplace issue, it's easy to kind of get caught up in recruitment and hiring and the nuts and bolts, but we sort of ended the session with the importance of creating a workplace that people want to pay attention to, the staff, supporting staff self-care, supervisors who are doing the right thing, agency that's focused on well-being and moving in that direction. Again, she reinforced the idea of good supervision practices and what happens when people are getting their sort of non-practical needs met in the workplace. Love this picture of people celebrating at work. Don't we all want to work someplace where there's confetti every day? But again, just kind of thinking not only about those tangible needs, but all these other ways that we address the human needs of our employees. So this is a schedule and the structure for what we did. Again, these slides will all be made available to you. I suspect that as part of the state TA task, we're going to continue to offer other learning opportunities, webinars, as Matthew said. I wouldn't be surprised if other documents or resources are made available now that you've registered for this. You are part of this conversation. So with that, I'm going to pipe down. And just a reminder, the chat box is open for you to do Q&A. We are going to hold questions and answers until the end of this meeting. Matthew will facilitate that at the end of this meeting, but get those in the chat box if you'd like. You can address them to specific people. But with that, Brandon's going to step up and talk about what's going on in Nevada and his takeaways from the meeting. Brandon, thank you for making time for this.
Yes, thank you, Jim and Matthew and everyone. Good afternoon, everyone. This is, I was thinking this morning how I'm going to angle this, I guess. And then I thought, why don't I just talk about the added value that has been brought by way of this learning collaborative. It brought a lot of my team here together to talk about what's happening in Nevada, particularly within the Division of Public and Behavioral Health out here in Nevada. It also gave me an opportunity to really look at Nevada and what's going on with the behavioral health workforce capacity issues and opportunities. So let me just lead by putting something in perspective. I've been in Reno for about 4 years, and I came from LA, and LA County. Okay, you could fit all of Nevada's population in LA County times 3. Okay, we don't have a lot out here, and that's what I've discovered. I like it. I like the space, but in terms of service and my career, there's a lot to do. There's a lot of opportunity. So with the a little over 3 million people in Nevada, there's a huge opportunity for us to use this learning collaborative and use the takeaways to start planning on the more micro level here within the division, and then also out in the community, and then on the macro level out there. We can talk about our society as a whole, but within Nevada, well, let me just start with the actual collaborative that we had started. I learned a lot from our team here. I didn't realize that Nevada has a huge health professional shortage area. I mean, it's just incredible to me. Most of Nevada, it's classified as a shortage area. So my team and I were talking about the SWOT, and that's what we got into. We dove in, we started talking about everything that makes up what's going to be the gap. And I've done plenty of gap analyses in my career. I like them. I like the process of discovering where we need to improve and what we're good at too. So for the purpose of this webinar, I'd just like to share a few things. We have a lot of strengths here, okay? Particularly with our division. There's a lot of loyalty among the state workers. There's stability in retirement and benefits. There are new bonus incentives that improves longevity and retention. There's also this transferability that happens that's very attractive to a lot of people getting into the field. And I have to say, I'm new to the state. I'm usually in the community working in the nonprofit sector. So this is quite a change for me, but it enables me to see kind of two sides to the coin in a lot of ways. But at the end of the day, when we do gap analyses, they're going to bring value to whatever we're doing. And so, and not only that, it strengthens the public-private partnerships out there. So anyways, so with those strengths, we also discovered some opportunities too. There's transferability, kind of rise in the ranks opportunities for state employees. There's an opportunity to explore different jobs within the state agencies. And there's a lot of funding to expand capacity and improve services. So weaknesses, there are classification issues regarding eligibility for bonuses. There's post-pandemic stability issues, which I think we all can identify with, no matter what state you're in. We had mentioned the lack of change management controls. And then in terms of threats, definitely future pandemics, health emergencies, the lack of qualified applicants, so on and so forth. So when we worked this matrix, what kind of came out of it was, well, what are we going to do? How are we going to convert those strengths and weaknesses and threats, or the weaknesses and threats, into more opportunities and build our strength, our bench strength for how we work in the community? And so with all that being said, we were able to look at a lot of common factors among agencies in Nevada and among organizations in the community. On top of the SWOT that we did, we also discovered that there are other community factors that impact what we do. I mean, there was huge migration from the Bay Area and Sacramento into Washoe County, and particularly Reno, that flooded all the markets, actually, it seemed. Housing, service, everything, huge migration post-pandemic. The resources here are scarce already. So this mass migration, it seemed, you know, I don't think it helped improve the situation. We have a lot of work to do, and we need to use our resources wisely, given the population and the demand and the needs of the communities. So where are some of the opportunities here, really? On the legislative level, or yeah, we'll talk about the legislature. There are different assembly bills and Senate bills that have come through. They're very promising. One of the Senate bills, AB 37, is specific to a workforce development center, which is huge. It'll cost about $2.5 million each year for the next couple of years, and then about $2.7 million after that. But that center is being designed to improve the building of capacity in our behavioral health workforce. AB 69 also expands repayment programs administered by the Nevada Health Services Corps beyond medical physicians. It should include psychologists, MFT, social workers, SUD and gambling counselors, and other licensed behavioral health providers. AB 45 is geared towards student education loan repayments. SB 431 improves reciprocity, and that was a big issue too, and one of the goals is to ease reciprocity between states. SB 431 is meant to improve that, so that there's this ease in credentialing or transferring of credentials and stuff. So I know they're working on incentivizing people to actually get into the field and then keep these incentives so that they stick around. We have a lot going on in the workforce, no matter, I mean, just across the board, especially post-pandemic. I mean, we have been, I think all the states have this compounding effect of post-pandemic, you know, related trauma in an industry where people normally have to pay attention to compassion fatigue and burnout and things like that. So there is this added issue that we need to pay attention to, and it changes how we do business in terms of recruiting and retaining and building capacity in our workforce here. And kind of moving on, let's see. So we covered the economics, the generational gap. You know, we're talking about Gen Zs and millennials getting into the workforce and you know, integrating them into a very evolved system of care with Gen Xers and boomers. I mean, it's the diversity is key, and us integrating the new talent into our workforce is we expect it to be huge, and we want to be effective at that. So what does that mean? It means we have to look at all these factors, help them realize that they're, you know, look, we'll get into the field. We're going to do everything we can to help give you a promising career, and let that be the driver. It can't always be about money. It's a lot of the drivers for health and human service professionals is the willingness and ability to help people improve their lives. And I know that's one of the guiding principles with SAMHSA. So we aim to focus in those areas. Next slide, please. So we do have the state health improvement plan and the workforce and pipeline development plan. We can't release that yet because it's being finalized right now. But I am able to talk about it a little bit, and it really, the bulk of it is that the development of that workforce center. And so that's one of the goals for our workforce here. It's to establish the Workforce Development Center and create a robust pipeline for behavioral health professionals that builds on existing successful programs, establishes new programs and training, opportunities, and enhances connections through the educational system and professional licensing. It's also going to improve recruitment and retention. It's going to reduce barriers to licensure and also increase use and integration of community healthcare workers. That's a huge goal right there. And I think that's a good starting point for what we want to do in Nevada. If we can establish that center and start attracting the right talent and work with all the other socioeconomic factors and everything else that we discovered in this SWOT and gap analysis, I think we might be able to pull away from being last in the country to and make these incremental steps to getting better and being more of a model of a workforce model out here in a place that has a lot of barriers, quite frankly. But behind every barrier or challenge for me is the opportunities. The cost of missed opportunities is huge. And as a business person, particularly, I like to avoid that stuff. We plan to build out whatever we can to integrate resources into our continuum of care, create these public-private partnerships with the government, all the local organizations, and really really crank out these goals and objectives that kind of boil down to what you see here on the slide, using programs and incentives, easing the reciprocity, leveraging non-monetary drivers behind professional commitments. And particularly here at the Bureau, I'm very interested in improving the application to onboarding process. It's a lengthy process, and I think that there may be times when they will lose candidates simply because of the length of time it takes to actually onboard somebody once they've decided to hire. So that'll be a goal within the Bureau where I work, and I will definitely be bringing that to my senior managers to have a nice, robust discussion about that, because I've been a big fan of human capital development. I'm glad, Jim, you mentioned that earlier. I've run a lot of programs in my career, and what I found over time was I liked that idea of human capital development. That's so essential in our when we talk about workforce development in any way. I like to see people find their path, do well, help other people, and feel good when they come into work. So that kind of overlays everything we're doing here at the Bureau. It's been my focus for the length of my career. And with that being said, I will definitely stay focused on the recruitment and retention strategic frameworks that we've already begun to discuss with our providers and people in the community. And I'll just kind of end with this. I want to build bridges and networks here in Nevada. That's what I want to do. And a lot of my team members and people I do business with, they feel the same way. I think that in order to protect and build any continuum of care in our community, we have to build those bridges and networks, share ideas. And, they say in marketing, like real estate, it's always location, location, location. Well, in this case, it's benchmark, benchmark, and benchmark. Okay, there's so much to learn from everybody across the country that I've stayed inspired, learning from other people in different cities and states. It's amazing, and we plan to keep doing that, and I will keep that as one of my initiatives as I do my work. We want to keep the balance between public and private partnerships, and practice what I call the 3 E's, and that's educate, engage, and empower. If we're doing that with clients in a program, or we're doing it with staff that we supervise, whatever, it works. It's a formula that I found that works. If we're doing those 3 things, then we're going to have a pretty dynamite workforce that's going to be able to serve a lot of people. This issue is deep. There's a lot of depth and weight to it. There's not one single solution, but I know that these types of things that SAMHSA has put together with the Learning Collaborative bring so much added value to what we're doing. And it just, if anything, it has made me think about how big this issue is, but also how we can solve it and use our government to improve the situation, and also empower the local organizations to improve their capacity so they can serve a lot more people. There's a lot of good people doing a lot of good work out there. Nevada is no exception to that. We need to have a very strategic focus here and build our resources and mobilize it so that we can not only compete out there in a way, but also get better. And what that means, in as far as I'm concerned, that means helping more people. And that's what we plan to do. So sorry if I went over a little bit. And I think that'll wrap it up. I appreciate the opportunity. I had all my notes laid out, but I appreciate the opportunity to talk about it and be inspired by other people doing this type of work. So thank you, and I'll leave it there.
Great. Brandon said exactly what we needed, brother. Thank you. Thank you very much.
Yeah, you're welcome.
Big mahalo for waking up a little early. I hope he's had a little Kona coffee. My cousin John joins us from the Department of Health in Hawaii to talk about his experience in the collaborative, what they learned, what they took back. So John, mahalo and welcome.
Mahalo nui loa, Jim, and Matthew, and Brandon. So thanks for having me here in space today, and for the privilege of really presenting and talking about what Hawaii experiences, and particularly with respect to this learning collaborative. I mean, even just over the last half an hour, I've just picked up quite a few more things. And that's one of the beauties of these learning collaboratives, is that, the more you participate, you get out of it what you put into it. And if there's a part of you that says, I'd like to be part of this, I'd like to apply myself and to learn, and to, as Brandon said, we're willing to educate and engage, then you will be empowered. And so I'm really, again, thankful for this opportunity. Next slide. So just a little bit about us. I'm a division manager at the Alcohol and Drug Abuse Division at Department of Health in Hawaii. We're known as the Hawaii Single State Agency. We do non-direct services through community providers using a variety of federal block grant and discretionary funds and state funds. And over the last year, we've served. We're a small, very small state of about 1.4 million people. Through our non-direct service contracts, we've served about 4,400 adults and adolescent clients through treatment services, about 19,000 through prevention services. COVID has impacted us. Usually the pre-COVID numbers are usually over 5,000 treatment clients, adults and adolescents, and over about high 30 to 40,000 prevention clients. So we're still trying to rebuild from COVID, and trying to engage the youth to return to kind of re-engage back with us. And so our providers did have challenges as a result of the pandemic, and of course recently, as we've heard in the news, there are a lot of folks that do need jobs in Maui, and so we've been involved in lots of different meetings. A lot of FEMA folks are here to try and help assist the recovery, and which will take a long time. And so it presents, yes, it presents challenges, but those challenges can be viewed as opportunities. And I believe, if I forget what language it said, the word for challenge. In one particular language, it said that the word for challenge is actually defined as opportunity, and I really like that. That how you can reframe something that could easily a negative into something that is positive, and which kind of gets at the definition of resilience. And that was something that was talked about during this learning collaborative, that resilience is not so much what happens to you, but how you respond to it. Are you going to let this challenge bury you in the sand, or are you going to use this as an opportunity, a springboard to help not just yourself and your agency, but your community to rebuild? And so that's something I really picked up through this learning collaborative, and we hope that more of you, especially my state counterparts, would avail yourselves of this opportunity as it is presented to you by SAMHSA. And to the SAMHSA folks out there, thank you so much for having us participate in this. It's definitely opened my eyes in lots of different ways. We just completed a long-range planning effort. It's available on our website. But one thing that was noteworthy was that we looked at our long-range plans that were done 20, 30 years ago, and workforce development was not part of that, was not one of the core objectives. Well, guess what? Now it is. It has its own component, along with data, the need for data, improve data management, improve services, improve infrastructure and capacity within our agency. But that we definitely need to focus on workforce as a separate component. And so we need to be intentional. And I think the Learning Collaborative really helped us to be intentional about that, to say, okay, we will make a concerted effort, not just us, but those we bring around us and surround us with, to learn together and to continue to learn together, because this is not something. Workforce development challenges is not something that you can just microwave and a solution. It takes concerted effort. It takes time. It takes you bouncing ideas and suggestions off people. It takes collaboration. Collaboration is a must. And so it's a bit more effort than what maybe our predecessors at my agency have done, but we're definitely committed to this road to rebuild, road to recovery, road to resilience. Just as far as our workforce stats, we have about 1,500 substance use counselors, 900 in training, and we're trying obviously to build up our prevention specialists. We need a lot more prevention. When I came in, there was like 40% reduction in our prevention workforce. And so at least now this number is higher than what it once was 5 years ago. So that's a good trend and encourages us to keep moving forward. Next slide, please. So one of the challenges that we faced was how to add to our work, our workforce in those with lived experience. We began, for example, something in 2017 called the Hawaii Opioid Initiative, and it was a mix of those from agencies and professionals, pharmacists and law enforcement and such. But one category that was missing was those with lived experiences. And so this Learning Collaborative in particular emphasized the need to include peers. And how do you support peers, not just train them up, but what are your strategies to find gainful employment for them? And so our takeaways as a result of the distinguished presenters at this LC our takeaways was, number one, we need to develop more outreach. We need to obviously finish our rules and to credential the peers, but also try to work with a couple employers to place them, and also set some goals. When I came in, for example, about a little over a year ago, our vacancy rate in our agency was like 50%. And so as of last month, we're down to 30%. And so we've been taking that concerted effort to try to fill our positions. And the same level of effort, I think, applies towards peers. And we need to pay attention to the needs of peers and how they can be part of our continuum of care. And that's obviously an ongoing conversation with our clinicians and setting smart goals with them. The other challenge that we have is, trying to compete with the private sector and offer competitive salaries and fair wages. We do have some tools through the civil service process. Our department does have a salary matrix, which we worked out with our HR department, particularly for the professional classes like psychologists and such. But one thing that we lacked was doing a rate study. One of the things that this learning collaborative really did for me was reminded me of other experiences that relate to workforce development. So for example, for this rate study, there was a bill in the legislature last year talking about the need for us to develop some sort of value-based purchasing agreement or value-based purchasing structure, which some of our managed care and Medicare has obviously have more experience in. And so hearing the coming into this collaborative space with this challenge, reminded me that, okay, yes, our rate study, we launched with another mental health division, sister division, is a big step in the right, we're going in the right direction. And so we are about to launch our rate study for substance use professionals that looks at our prevention rates and our treatment service array. And hopefully that'll result in a more empirically based, not rates for the short term, but also help us to venture into developing value-based purchasing rates for maybe a few of our services, say our opiate treatment, our methadone maintenance types of services. So obviously this is something we need to work with our developers, but our providers, along with our actuarial consultant, but we're really excited about this. And thank you to this LC to really confirm that we're going in the right direction. And this rate study also was a recommendation from our advisory commission, which is down below. Next slide, please. I'm not going to talk too much about the SWOT exercise that was shared. It is definitely, there are parts of workforce development that aren't rocket science. But going through it is definitely helpful, and particularly as you go through it with your brain trust or your team, we work with a team of committed professors at the University of Hawaii School of Social Work as the basis of that. And the more we have conversations with them, the more we're thinking, okay, who else do we need to have at this table? And so what they did was they expanded in order to develop their workforce development plan that they're sending to us. They've convened their own advisory committee of other folks that represent some, for example, those are who are in the provider community or in the cultural practitioner community. And so, just trying to get that wide, broader representation. And so for us, we will apply the SWOT and to our do it as a team, and maybe do it regularly, and for our workforce coalition led by the university, and then even share the SWOT results with our advisory commission, who annually writes recommendations to our legislature on what we should be doing and focusing on. So, trying to get alignment in many different ways. And so it not only benefits these different groups, but it'll hopefully the synergistic effort will result in other collaborative efforts to build capacity for training, recruiting, retaining our workforce. The other, this LC also helped bring subject matter experts, and so I think you're going to hear from one of them in a few minutes, just particularly on the recovery. And SAMHSA has been big on promoting recovery, and I think this is very timely. We've also heard from our GPO, who has really been instrumental in helping us better explain the nitty-gritty in terms of how recovery and the federal regs. And so it's given us a lot of content to work with. And for us, we definitely want to expand our recovery capacity beyond clean, sober homes. We feel that we're behind the others. The other states are more ahead in terms of how they interact with peers, employ peers, and support peers, and also the different types of homes that they have, and the variety of things they do with those who live in the homes that are very patient-centered. It's really admirable, really encouraging, and really inspirational. And so thank you again to this opportunity to participate in this. So we'll continue to build that credential and learn from other states. Next slide, please. So this is sort of our takeaways, and we need to finish development of that peer credential. Earlier, Jim mentioned a speaker that basically said every student needs practical experience, and I just want, it's not in this slide, but I think I should, it's worth repeating. What the recent successes we've had with workforce development is definitely those who have agreed to be 89-day hires, or who were temps employed to us as a result of a COVID contract. All of those who were temps are now in civil service positions employed with our agency, including many of our emergency hires. So it definitely helps, whether you call it an internship, a non-paid internship, or a paid temp, or an emergency hire sort of position. Giving them the opportunity to test drive was definitely a big sell. And also, if they lived in the area, that was another big benefit, or that to attract them. I just thought I'd mention that. We also will found as a result of just this organic communication and trying to build with other training entities, we found a willing partner in a local community college on Hawaii Island, on the Big Island, to coordinate course offerings for emerging substance use professionals. Their School of Psychology is actually wants to develop a CSAC, or counseling track, so that those students can be trained on island. And so we will be working with this with the University of Hawaii at Hilo to try to build that and to coordinate our course offerings that we offer with what they offer at the community college level, so that when they're ready, when they're all done, these candidates could be ready to test. And so really excited about this as a good pilot to maybe work in other community colleges. And we find that community colleges tend to be siloed in their own way. And they each have run their own functions. And so finding those good partners that are willing to work with you is really goes a long way. But it does take effort and putting yourself out there. And I'm an introvert, so to do this, it doesn't come natural to me. But nevertheless, this is what's needed to address our challenges, and we're committed to it. We're going to continue to make note of our current strengths, like our flex hire, our salary matrix, and other tools that we have. But we'll also apply ourselves on this new rate study, and we'll look at pay scales for peers. Currently, that's not part of our service. Actually, well, it is part, but then maybe it could be expanded or modified somewhat, particularly if they're working on a neighbor island. The rate study could maybe offer some recommendations for, adjustments for rural remote areas, that sort of thing. Because the cost of business in a rural remote area is different than if you're in downtown Honolulu. We'll respond actively, recruit vigorously. Obviously, we're going to talk story with other. That's how we say it in Hawaii. Talk story, keep it informal, and then as they open up, our cultures here tend to gravitate around food quite a bit, and if I do that, I obviously have to exercise just to stay fit. But if it's necessary, then we're going to continue to do it. And we found that talking stories sessions with different folks, different parties, different providers are very helpful in order to move forward. And it allows us as an agency to present ourselves as, we're coming around to support you. And we're not just here to, point the finger or here's your contract, but we want to give you the tools you need, and, we'll get out of the way if we need to. And also, we'll definitely continue to learn from SAMHSA's rich resources and sites. We're going to continue to, one of the ways that we're going to, besides SAMHSA's resources, we're going to look at other funding sources like HRSA and CDC. There was one opportunity that HRSA recently put out for a loan repayment program for substance use disorder treatment and recovery professionals. We're going to look for more opportunities like that, and look beyond. And I'm so glad that other states are. We hear that they're looking at other sites, other funders, even HUD, because HUD sometimes puts out things for opportunities for substance use. So we're going to continue to look in those areas. We're also going to work with other agencies. One of our agencies is recently applied for and received a CDC infrastructure grant. Again, we're going to look. We'll see what that does in order to help build our workforce. But again, partnering up with local agencies, even within our department or other departments, and whoever we can, collaboration is a must. I think that's about it. I could put my email in the chat if you wish to chat with me further. But again, thank you so much for this opportunity to present and speak before you all.
Great. Thanks for talking story, John. And what I should have said earlier, John, I hope you know there are millions of us looking at Maui and praying for everybody's health and resilience as we look at that disaster. So please know, especially those of us who've been to Maui, you are in our hearts. Thank you.
Thank you.
So Jessie Bokey joins us. As I said, she's the University of Nebraska. They're doing some innovative work on solving the problem. She was one of our rock star presenters, I'll say it. And so we've asked her to join us on this wrap up, not only to highlight what they're doing in Nebraska, but also to look at the larger landscape. So Jessie, thanks again. And I'll turn it back to you.
Thanks for having me. I'm glad to be back again. There's nothing I like talking more about than workforce and behavioral health workforce, which is probably the nerdiest thing ever, but super useful for this and for this audience. Jim's right. I'm now working at the University of Nebraska Medical Center for the Behavioral Health Education Center of Nebraska, but got my start in workforce research in a HRSA-funded health workforce research center at University of Michigan, where I was one of the founding researchers and managing director of the Behavioral Health Workforce Research Center. So have been either conducting the research and making policy recommendations, or now looking at actual workforce development programs and evaluating them for a long time now. And so this is just really what I love to do, and I love to talk about it. So I will. Slide, please. So we heard from Jim and John and Brandon about some of the challenges to recruitment and retention. We heard a little bit about some of the state initiatives from Brandon, from both Brandon and John, about some of these network building opportunities in their states. Where I'm going to hit is also on some of those things, but also on kind of the importance of data and evaluation and lack of it. So I told you I was working for the BHWRC for about 10 years, and one of our last projects that we had was to develop a toolkit to on best practices of behavioral health workforce recruitment and retention in rural areas. We did about 72 interviews, one in every single state, whether like state entities, with nonprofits, with places like Beacon, where I work now. And some of these questions are what came out of it, more questions than answers. But what we really kind of realized is that there were no evaluated or established best practices that we could produce for our toolkit. None of these, a lot of the initiatives had been tried, but very few had been tested. And so that is kind of an important corner we're turning at Beacon, and hoping to put some literature and data out there about the dearth of, to kind of cover the dearth of research that is available on some of these best practices and evaluation of recruitment and retention for the workforce. Slide, please. So we're all aware of our federally funded initiatives. John just talked about the National Health Service Corps and their loan repayment programs. We know that's available for our licensed behavioral health providers, psychologists, psych nurses, physician assistants, and for our psychiatrists. And programs like this tend to be really useful in rural areas as well. In terms of recruitment, data kind of shows that it has less impact on retention of the workforce in some of those rural areas. We know that state-funded loan repayment programs are matching some of those federal loan repayment programs like National Health Service Corps. And then we also know about HRSA-funded training initiatives like BWET, OEP, and GPE, which BWET is training and education and internship opportunities around integrated care for underserved population. OEP works on SUD populations, and GPE is for psychologists. And again, these are often putting trainees into either medically underserved areas or some of our rural areas as well. And then we have our minority fellowship program and technical assistance centers for SAMHSA. And I just saw, it might have been a week or two ago, that SAMHSA put out one of its key initiatives is going forward is working on building the behavioral health workforce as well. So I expect to see more funding opportunities coming from SAMHSA in the future too. And then of course we have our AHEX, which is working on training and education and awareness, building awareness of all health professionals, but behavioral health professionals as well. Next slide, please. I'm going to do a little bit deeper dive into some of our state-based initiatives and specifically around a lot of pathway programs, but some other unique opportunities I'm seeing kind of scattered throughout the country, but not pervasively, is the increasing Medicaid rates. I know this just happened in Nebraska for licensed behavioral health providers. Expanding scopes of practice, especially for provisionally licensed providers, or even adding or increasing reimbursement rates for our peer support providers or community health workers or patient navigators I'm seeing in some states. And then in New Mexico and Oregon, something I saw that I thought was a little unique and I'm not seeing everywhere is adding tax credits for rural psychologists there in New Mexico, and in Oregon for prescribing populations practicing in rural areas. There's also a tax credit. I think it's up to about $2,000 a year as well. Next slide, please. I'm going to talk about 3 really innovative statewide strategic initiatives. The first being in Nebraska, where I work. It's the Behavioral Health Education Center of Nebraska, and it is housed in the University of Nebraska Medical Center. While I was at University of Michigan at the BHWRC, I was doing a lot of research in partnership with Beacon, and that is one of its. I have 4 kind of chief initiatives here, but I think they really have, Beacon really has 5 key elements to it. And one is collecting and reporting on the behavioral health workforce data in the state. And they use that data to make policy recommendations to the state and use it to find legislative champions within their legislature to help move some of these recommendations or initiatives into law and into bills. And so that has been a really key component to building a transformational research center. Our kind of next key element is that we are a geographically diverse state. As you may know, most of the population is located on the east side of Nebraska near Lincoln and Omaha. And so we have a lot of rural and frontier areas. And like Brandon said, in Nevada, the majority of our state is a medically underserved area, or HIPSA. And so to address some of those issues, we've developed satellite sites. We have our Beacon Panhandle out in Chadron and Scotts Bluff with representatives there. We have Beacon Central in Kearney. We have Beacon Northeast up in Wayne, and now are developing a Beacon Southwest. And a really key component of this is developing these networks with other academic institutions and other training sites so that we can expand the behavioral health workforce, not only to these rural areas from Omaha, where most of the academic institutions are, but also to other colleges and universities spread out throughout the state. With that, we have a really strong training and education component at Beacon. We offer stipends for training and internships in a lot of these rural and underserved areas. Some of it's through an application process, and some of it is through fellowship opportunities with UNMC. But we are something that I think has been really unique and a really great opportunity to reducing the burden of obtaining a behavioral health degree is providing those paid training opportunities for students to get their experiences in some of these rural or underserved areas. So that's one of our other key components. And then we have a really large recruitment and mentoring component to Beacon, which includes an ambassador program, which is about increasing awareness for sometimes middle school, but definitely high school and community college students around behavioral health workforce opportunities, recruiting with some of our satellite sites at like University of Nebraska Kearney and Chadron, Wayne, and UNO and UNL, to move undergraduate students into graduate program opportunities by kind of creating, I think, more universally known as like a 4+1 program. So 4 years of undergrad paid for if they, agree to stay in that school system to go to graduate school as well. And that it also includes paid internship and training opportunities as well. And I think this comes from a lot of data and research that, I did at the BHWRC, where we found that one of the biggest barriers, especially for some of our providers of color to entering this workforce, is that they are required to get a bachelor's degree in 2 years of graduate school, and often are required to have training and education opportunities that aren't paid, and then are moved into a provisionally licensed position where they are, again, not reimbursed at a very high rate for a few years. And it's just like the juice isn't worth the squeeze a lot of times. And so these training opportunities and education opportunities and mentorship programs are aimed to get them through the pipeline or the pathway, while reducing some of those barriers that they might otherwise have. And then what I'll talk to you even more in depth about is the American Rescue Plan Act Awards, which is the program that I'm directing at Beacon, and the effort that we put into building the workforce through some of those ARPA dollars. Next slide, please. So Brandon told you a little bit about the statewide strategic initiative coming from Nevada, Assembly Bill 37, that was passed just this summer to establish the workforce in Nebraska. That came, I think, on the heels of some of the presentations that a few of our Beacon leaderships members did over the last couple of years. And they have been working with Beacon to develop a really similar program. A lot of those mentorship opportunities, building of pathway programs, training and education opportunities. And I think, Brandon, you said a little bit more, but 2.5 million is allocated for this first year into the development of the system. And that's going to be housed at UNLV with other academic institutions as part of that collaborative network. And I think we'll see in the next slide in learning about Illinois. That's a really, really key component, as you saw it with Beacon and with this new collaborative in Nevada, developing those networks as well. Next slide. And so then earlier this spring, Illinois, with a $5 million per year state investment, passed a similar model to Beacon and Nevada. They are housing their Behavioral Health Workforce Development Center at Southern Illinois University's School of Medicine, and they are partnering with other social work and academic institutions to, again, create a collaborative network around building the workforce. As with Nevada, Illinois, Nebraska, they have larger city centers and then a significant portion of their population residing in HPSAs or medically underserved areas. And so the creation of these networks, whether it's with academic institutions or training and internship sites, working together to establish even greater partnerships with private and public institutions, as well as even working with community colleges, has been, I think, really the key component, not only to building this network in these development centers, but also to creating bipartisan buy-in from legislature to get this type of funding as well. Right now, kind of the next steps with Beacon evaluation and our, continuing to expand our transformational research is to evaluate some of these networking opportunities and networking systems that are existing among, that Beacon has created and exist among Nebraska, to kind of create that best practice to show other states how to build that network and how to do it well and how to adapt it for the needs of other states as well. Slide, please. So I'll dig a little bit deeper into American Rescue Plan Act funding, but before I do, I'll just, have a friendly reminder that this $25 million that we received of ARPA funding came from that interim study task force and from Beacon research that we did on the behavioral health workforce in Nebraska. And so it's showing the enumeration of the workforce, the interviewing behavioral health providers and publishing this data, whether it's in a peer-reviewed journal or just among the state or on our own Beacon website. It's what drove this task force study, and then ultimately this legislative bill 1014 to get this funding and the bipartisan support in Nebraska to build the behavioral health workforce. And so that was a really key component in getting funding to have this initiative. Slide, please. For anyone new, and some people might have heard from me a month or two ago, but the Beacon ARPA Awards program has that $25.5 million that was allocated to any organization in Nebraska was eligible to apply for through a competitive application process. We had our first cycle in October of last year and received 200 applications. And then our second cycle started in February and had 150 applications in between those two cycles, requested funds totaling more than $75 million. And as a reminder, we only had 25.5 available. We had 4 application categories in which folks could request money. The first, a lot of them are really in line with our Beacon initiatives, that first coming from behavioral health training opportunities, which really opened up a lot of opportunities for universities and internship sites to expand rural and diverse training opportunities for licensed behavioral health providers or future licensed behavioral health providers. And I think the lowest hourly rate of internship stipends we saw coming out of those awards was about $18 an hour, which I think is far greater than we see most interns having the opportunity to be reimbursed for their time. I think a lot of those tend to be volunteer more than they are paid. And then our second category was the expansion of telebehavioral health infrastructure in rural areas. If we couldn't get providers to go to our rural and frontier areas of the country, we thought we would build our telehealth infrastructure and take our urban providers to rural areas that way. The third category is workforce projects related to COVID-19. Many of the projects that came out of this or that were awarded from this category were solely around recruitment and retention of the behavioral health workforce. So I'll dig into that a little bit deeper. And then lastly is the funding for supervision of provisionally licensed providers. And I actually think that this category and the awards that were dispersed has the most potential for showing growth in the workforce. So as many of the folks on this call know, our provisionally licensed providers often can't be reimbursed for their services, or they have a really low reimbursement rate. And many times those supervision hours that go towards those providers can't be reimbursed. And so this funding mechanism allows for supervisors to still be paid for supervision hours, for preparation hours, and then also, these are hours that are away from clients. And so it's hopefully filling the gap here and allowing them to be providing more incentive for supervision and hopefully moving our provisionally licensed providers through those pathways quicker. Slide, please. So this is just a really quick breakdown of the funding that went to some of these 4 categories. We had nearly 12 million going towards behavioral health training and education opportunities, about 7 million towards our telebehavioral health in rural areas, a little over 2 to those workforce recruitment and retention projects, and almost 2 million for the funding of supervision of provisionally licensed providers. Please check on our Beacon website, where we are frequently updating and highlighting some of these programs. We have a whole kind of magazine coming out that's highlighting some of the stories and how they're using the funding and how it's already going towards the growth of the workforce. Slide, please. What I really want to dig into is that recruitment retention category. that I think has some really unique ideas coming out of it. We had 31 awards going towards recruitment, retention, and resiliency building efforts of behavioral health providers. One group I want to highlight is at University of Nebraska-Kearney. For those familiar with Kearney, it is considered a bigger city in Nebraska, but the surrounding area is very rural. And so they have a lot of students from rural or diverse backgrounds coming into UNK, and they have proposed to establish a student ambassador program that goes into community colleges, goes into high schools, and really trains and educates and builds awareness on the impacts of COVID-19 on their rural population, and then at the same time educates and builds awareness around behavioral health career opportunities. And so a small component of this will be for UNK undergraduate students to have stipends for internships in the behavioral health field so that they can hopefully move along the pathway into graduate school as well. At Heartland Family Services, this is in Omaha, but have do work in greater Omaha area that also has a pretty significant rural component. They are sending 14 of their behavioral health clinical staff out of state and out of their area of practice to do a resiliency building workshop and hopefully to reduce symptoms of burnout among these providers. I think it was really important for the folks writing this grant, the leadership at Heartland Family Services, to remove their providers from their area, from where they were local to, so that they could feel really open about sharing in their experiences and their burnout. They are paying for the travel, lodging, the training, and they're paying for the time missed of providing services to their clients as well. So really reducing any barriers that any of their clinicians might have to receiving this training, and really hoping to help reduce burnout among their clinicians as well. And then finally, we have Wholeness Healing Center. They're doing a training as well. They're calling it their Wholeness Resiliency for Therapists, and providing opportunities to their clinical staff to unpack the effects of COVID-19 that impacted them as behavioral health providers as well. We saw a lot of these awards providing recruitment bonuses to actually get providers to fill, years-long vacant positions. We found a lot of retention bonuses for providers that had stayed on in the organizations through COVID-19, building on amounts received for those retention bonuses depending on how long they've been there. We saw some of these bonuses being used, or some of these funds being used to get folks to pay for their moving fees to get out to the Panhandle, because that seemed to be a really big barrier to establishing workforce or filling long vacant positions as well. So there were some really innovative ways to building resilience among their providers and retaining providers as well. Slide, please. So the ARPA dollars is where I'm kind of seeing the most innovation statewide. Really similarly to some of those funds for the supervision of provisionally licensed providers in Nebraska, Wisconsin's doing the same thing, distributing funding to reduce the burdens of supervision and moving providers to full licensure. They have another close to 2 million distributed in grants to hiring just supervising providers to hopefully, again, move folks through the pathway. And then they've also developed and implemented a supervision best practice toolkit with all of these ARPA funds. Slide, please. In Maryland, we have seen 27 million ARPA dollars being allocated to mental health and 27 to substance use disorder health through block grants. And among those 27 million in each category is some workforce initiatives, specifically workforce training for peer recovery specialists, for our residential rehab specialists, and then around medication assisted treatment. Next slide, please. And then in Maine, they've allocated funding for earn as you learn job boards in behavioral health for behavioral health professionals, including certified drug counselors, peer support providers, registered behavioral health techs, and mental health techs as well. And I think similar to Maine and Maryland, investing in these certified behavioral health professionals or non-licensed behavioral health professionals, one, reduces the burden on more typically researched behavioral health providers that are clinically, that have clinical licensure or are prescribers. It reduces the burden of them. They are kind of seen as service extenders to those types of providers. But I think it's also important to invest in these types of non-licensed providers, because they are a key component in the pathway of workforce possibly achieving full licensure and continuing along a behavioral health pathway as well. So it's really great to see states making this type of investment. Slide, please. It's my last, I think. So a summary of our these recruitment retention responses. Using these innovative funding mechanisms like ARPA or HRSA cooperative agreements or SAMHSA workforce grants have, I think, shown to be really promising practices. I'll skip right to the third bullet and just kind of hammer home that there's an importance around collecting uniform evaluation data of any of these programs, because without it, it's really impossible to establish a best practice if we're not evaluating the effectiveness of the programs. And then finally, I touched on it a little, but want to kind of, again, come back to that, and which is building these networks among academic institutions, private and public organizations, and then working with bipartisan legislature to kind of champion these and to allocate money that isn't term limited to state budgets to help grow the behavioral health workforce. And I think that's where we're going to see the most concerted effort and the most change coming out of states like Nebraska, Nevada, and Illinois.
Thank you, Jesse.
You're welcome.
Thank you, Brandon, John, Jim. Thank you all again for your presentations this afternoon. At this time, we will begin the question and answer segment of the presentation. If you've not already done so, please submit your questions by using the Q&A feature located at the bottom center of your screen. Our first question: which federal agencies is the ARPA workforce funding from in Nebraska?
Well, it comes from the, I don't know where it comes, Department of Treasury from the federal government. That's where it was allocated to the states. And then I have not worked at all with the federal agencies. I'm working with the Nebraska Military Department at the state of Nebraska. I don't know why the funding went there. No one does, but that's where it went from the Department of Treasury, U.S. Department of Treasury, to the State Department. At this point, in terms of funding distribution, I would work with state entities to see if there's remaining ARPA dollars to be distributed. And I know a lot of it went to counties and went to health departments as well.
All right. Our next question: can you please talk about role ambiguity and its impact on retention?
Brandon, you want to get in?
Yeah, just a little bit more specific though.
Yeah, I think just when you any kind of role ambiguity, so maybe you're hired to do one position and maybe the KPIs or the key performance indicators within that position, maybe it's not necessarily clear, and maybe what that means for the staff who's in charge of handling those KPIs.
Absolutely. So in my career, I've held a lot of senior management positions, and I've always ensured that when we hire people, they know what they're being hired for, number one, and then we stick to, sometimes there's blended functioning. I mean, that's just as an agency grows, maybe people kind of blend their functions. But I'm a kind of a stickler to what I'm hired for and what I'm supposed to do. I do whatever it takes to get the job done, but I understand that a lot of staff, maybe frontline staff, want to stick within the parameters of their job description or their work performance standards. And we respect that and stuff. So in terms of role ambiguity, I would just suggest get with your senior management and have them clarify the role definition or the job descriptions and make sure that they feel safe to do that. I mean, it's not like, well, that's not my job, some people are going to go, well, it's not my job, but I'm going to help out anyways. But we also respect the fact that people want to stay within some parameters. That's fine. But it's about communication and clarity and not feeling vulnerable to kind of do that. That's how I would handle it. Welcome them in, and let's clarify.
All right, our next question. Can you please address the saying, people don't leave jobs, they leave managers?
Did you say they don't leave jobs?
Yes.
They leave managers? Well,
yeah.
Am I handling that one?
Sure, you can get started,
okay.
Brandon. And then Jesse, I'd love to pull you in just based on your reaction.
Yeah. Like I had mentioned earlier, when I got my MBA, I thought I was going to do a lot of marketing. I fell into human capital development for some reason, and I appreciate it. I love it because I see the benefits with building a great team. And it depends on what your style is, honestly. Is my management style laissez-faire, do whatever you want? No, it's not going to happen. Is it more democratic? Yes. But underneath that, it's also empowering. I believe in empowering people, engaging them. I want them to replace me at some point. And that's the culture that we can keep. So if you have like a mid-level manager that might be problematic, or you see people leaving and there's this kind of continuity in what they're saying as they leave in their exit interviews and stuff, there's still a teachable opportunity for that mid-level manager. And so, but if you keep a culture where people can know their roles, understand what management does, and create a space where they can dialogue, that you will usually solve the problem. I have, just as an example, I have always included everybody in strategic planning. I might be responsible for elements of the strategic plan being implemented and executed and stuff, but I believe in bringing my team in so they understand exactly what the process is and what's expected out of it. And that's empowering for them. So on a leadership level, there's not going to be too much of an issue. But at the mid-level, yeah, there are personality conflicts and things like that. I was taught, and I'll end with this, but I was taught a long time ago. I had a director who was very challenging to deal with. He scared us, actually. We were new into this field and whatever, but he told us, don't ever leave because of someone. And it always stuck with me because I would be challenged with managers or directors growing up in this industry and stuff. And I never left an organization because of someone. It was because of maybe I had a better opportunity or whatever. It challenged me to figure out the problems that I was having, whether it be communication or whatever it may be. But don't ever leave because of someone. And I always carried that with me. And I've only actually left a couple of jobs in my 22-year career. So these things are teachable, or they can teach us and inform us. And that's what I would tell people who might be struggling with managers. Don't leave because of someone.
Thanks, Brandon. And before we go to the final survey, Jesse wanted to give you the opportunity if you had anything to add.
Oh, I don't have a lot to add to what Brandon says, but I would just kind of caution around especially behavioral health and supervisors and managers in this field. is that a lot of them might be in the supervisory role or in a manager role, depending how big an organization is, without any experience or a directive or education around what being a manager or a leader is. They just found themselves in this role, and so they're still learning too. So I think it goes to show that there is a substantial amount of training that needs to go into managers and leaders and how to build a team and manage a team and grow a team that just doesn't exist, and managers kind of find themselves in as well.
Thank you, Jesse. This concludes our question and answer portion of the webinar. As a reminder, the recorded webinar and PowerPoint slides will be made available and sent to participants at a later date. Before we get to our questionnaire, just a reminder that should states be interested in learning more about TA and resources, you may contact our SAMHSA State TA at jbsinternational.com email address. Next slide. I just want to acknowledge our presenters again this afternoon, Brandon, Jesse, John, Jim. Thank you all so much for being here. And we did want to give our attendees the opportunity to complete our evaluation. So if you can access the link by using your camera, you also see the web address on your screen there. It just takes a few moments to complete, but we are looking for 100% participation. So if you can, just as we're closing, please take a moment to complete today's evaluation. That would be fantastic. The link will be left up even when the webinar closes, so take as much time as you need. Again, thank you all for taking the time to be here this afternoon. If you have any questions or concerns, please don't hesitate to reach out. Thank you, and have a great rest of your day.